Thanks very much, Dr. Harris. I've been practicing in the community in southern Vermont for 26 years now and been very interested in electronic health records and using them in my office since 1998 when I went into solo practice. Previously was part of a 4-physician primary care group that was affiliated with a hospital. Right now I'm entirely community-based. I no longer do hospital rounds. I have an excellent group of hospitalists covering my patients. I'm part of on staff of a 100-bed community hospital in southern Vermont. I really enjoy the part of my practice that allows me to give really personalized care, good continuity, and to be very cost-effective with patients. I participate with University of Vermont in training medical students, occasionally have a resident come to my office. Back in '98, I had a very bare-bones software system that was basically word processing, a database. It got the job done. Last year, I converted over to a CCHIT certified maximal strength electronic health record, and we went live in July with that. The reason we went into it was there was a recognition that in order to meet the needs of the future, we were going to have to do performance-based monitoring of our practice. We had to do something more than just fee-for-service. We wanted to go with a CCHIT certified EHR. My office would not have been able to do it without a very generous grant from our hospital, which allowed a $45,000 grant over a several-year period, covering 85% of the cost of the software. So we're still in the process of using that grant to pay for the ongoing expenses of running it. Our hospital also had the wisdom to set up an EHR collaboration group. Other physicians in primary care practice get together every month, and we talk about some of the problems that we're having in transitioning to electronic records. I'd say about 2/3 of the group are using my EHR, and the other third are using other vendors. And there's a lot of commonality in discussing workflow and customization of healthcare using the EHR. So it's been very helpful. And the attendance has been excellent, not just from physicians, but all of their staff. I've got to tell you that right now we're almost a year into the process. We can't go back. My staff likes the program in general. It's been a tremendous effort to move all of the pertinent patient information from one EHR manually to another EHR. We're still wondering about the CCHIT certification process, aren't really sure that it improves care that justifies its cost. Again, we're really fortunate to have that grant. There are a lot of workflow improvements that involved a lot of costly customizations of our EHR. And we're still wondering about the meaningful use requirements and the effect it has on increasing the cost of the health record. One of the things that we're struggling with at this moment is e-prescribing. The new meaningful use guidelines call for 75% of prescriptions being delivered electronically. Right now we're pretty happy with just faxing or handing people paper to bring to the pharmacy, but we're talking to our vendor. We're getting different opinions about how it would work with our system. The cost is still up in the air. We're having some problems right now with the laboratory data that we receive from our hospital. It goes through our statewide data repository into our electronic records. And in a small practice, it's very hard if you're missing data to figure out where the holdup is. So that's still a remaining question. Our statewide health repository is called the Vermont Information Technology Leaders. Right now we're doing one-way lab data import from them, but we're part of a pilot project to be one of the first practices that does a two-way interchange with the data repository, problem list, allergies, medications, and that's scheduled to go into effect in a few months. For the last 4 years, we've been part of the Vermont Department of Health's Blueprint for Health initiative, and we've been participating in pay-for-performance chronic disease management programs. Right now, we're expecting our data to go from our EHR into the statewide repository for data analysis by the Department of Health. One of the things that I've done over the last 3 years is had a freestanding web portal using a yearly contract with a large vendor. I've really found it helpful in reducing phone tag, in having a permanent record of electronic communications with patients. It's a great way of transmitting results for caregivers. They can participate in the process and read and offer information to it. It's been very popular with my patients. My practice has 700 patients enrolled with secure messaging. People ask for appointments. All of the privacy and legal disclaimers and web design are handled by the vendor. Doctors in small private practice don't have time to do this themselves. And occasionally I have people request a web visit where there's a fee rendered for me reviewing a problem and rendering an opinion. Some of the challenge involve, I've had to get my staff involved in watching the flow of messaging. I mean, with email coming in 24/7, patient expectations are pretty high for the messages being handled. I'm having my staff use broadcast email to specific groups, people who need, for example, the H1N1 vaccine or need follow-up care with diabetes. And one of the problems that I've had is it's very expensive to get a really tight integration between our EMR and the web portal. The other thing that I'm very interested in is in the having my office participate as a patient-centered medical home. We find that it's very important to be a certified medical home, to have a certified EHR. We're currently integrating our office staff in different ways using EMR. We're giving tasks to different people. I'm assigning, as part of the care plan, different tasks to my medical assistants. And the nurse that's working with me part-time is doing a lot of work in reconciling meds, in talking to consultants, making sure that patients, for example, who are discharged from the hospital or seen in the emergency room get seen quickly back in my office. So certification as a medical home and meaningful use is very important integration. Vermont is currently going to be working as a pilot site for the data repository, and as I mentioned before, the patient-centered medical home and the Vermont Blueprint for Health are going to be integrally part of that. Well, part of the problem that I'm working on right now is communication with the office team. We're developing document routing protocols, sharing protocols for care. We're working a lot in having patients interact with the electronic record in the exam room. For example, going over problem list and going over medications to make sure that they're reconciled properly. I think let's see if I can get it. We're seeing a big improvement right now in getting information into the chart. Currently, we have a fax server that's getting faxed information from visiting nurses, nursing facilities, and hospitalists and consultants. We're working now on computerized order entry, and there are a lot of time constraints for me to do all the computerized order entry. Right now, we're involving staff members in entering all this data and making sure that our whole team is involved with order entry and to make sure that the orders are completed. So with that, I think I'll turn it over to Jeff Blair.
Thank you. Okay, here's the, there's a remote, okay.
There's the button to move forward.
So I think we'll transition here now from the small physician's office
to now thinking about interoperability that's really going to be required to make a lot of the principles that you've seen earlier today happen. So, Jeff?
Thank you. As you know, being a blind person, I do things interactively. If I'm on the wrong slide, please don't be polite. Let me know forward or backward. So this is going to be the Health Information Exchange Network perspective on meaningful use. And this next slide should be what is LCF and NMHC. Loveless Clinic Foundation is an applied health research organization. So we're not a foundation, we're not a clinic, and we're not affiliated anymore, haven't been for 20 years, with either the Loveless Health Plan or Loveless Health Systems. We are very active in the community, and the fact that we are kind of the host for the Health Information Exchange reflects the fact that as an independent applied health research organization, 501c3 nonprofit, we play kind of a neutral role. In terms of NMHC, NMHC stands for the New Mexico Health Information Collaborative. It's the name of our HIE network. It's also the name of the stakeholder coalition that has created and supported the network. Now, Loveless Clinic Foundation was kind of the instigator back in 2004. So it created, and it staffs, and it operates the network. In terms of what does it do, it improves patient care by connecting physicians to electronic health record systems and electronic healthcare information that may be scattered over the community in different facilities. How does it work? The Health Information Exchange Network we have, since most of you, I think, are familiar with these, I won't go and elaborate through the flow, but we're what you might call a network that supports clinical information as opposed to administrative or e-prescribing. And we have a master person index, we have a record locator service. It's a hybrid model where many of the ed servers, most of the ed servers, are physically located on the premises of the healthcare providers that provide the data. Brief history of our development. NMHC began in 2004 by LCF with funding from AHRQ, 100% matching funds from the community. So that was $1.5 million the community invested at that time. In 2007, we were one of the folks to participate in the Nationwide Health Information Network Trial Implementations Program. That was outstanding. We grew very rapidly during that time and were able to be part of the trial connections to a number of other states and locations. We have been very active in privacy initiatives and security initiatives in our community. We were one of the initial entities that were part of the Health Information Security and Privacy Collaborative. As those of you who know that initiative, it wound up identifying variances in privacy and security policies among different organizations in your community. That led to some actions. One of the actions was that we went to our state legislature. We did a few things that were pretty basic, like making sure that healthcare information in electronic form was legal now, but it also included a framework of privacy and security laws in our state that would facilitate the development and use of electronic health records and health information exchange networks. We have 11, 12, by the end of this month, there'll be 13 hospitals connected to NMHC, 11 urban, right now 1 rural in Holy Cross in Taos, New Mexico, and by the end of this month, Christus St. Vincent in Santa Fe. We have the 2 largest medical groups, the 2 largest clinical labs, the largest ambulance service.